Did anyone actually try to access the video and populate?
Yeah,
Did it work?
Yep.
Okay, great. Awesome. I did look into it. I found out that the videos were not loading for all of you or me actually once I checked it because they're set to private. I made it to public, then they were made available to everyone, both face-to-face and online. So you should be able to access them, especially for next week as you study for the final exam. Please look back on the class discussions, look back on the questions asked if you need. So hopefully that'll help. Okay? All right, so let's start with a video tonight. You cannot see the video for some weird reason. I don't know why, but you can hear the video. So I'm going to be playing a video by Dr. Daniel Amen. He is a psychiatrist who is very well known in the psychology field. Now, he's well known in the psychology field for two main reasons. One is for his work with SPECT scans. So that stands for basically single photon emission computed tomography, which is very similar to an fMRI brain scans. He's very well known for his work with brain scans. He introduced the revolutionary concept of using brain scans to determine behavioral issues. He states, and as we will hear, that a lot of the medical field and practically every area in the medical field uses scans of some type, x-rays, brain scans, even for traumatic brain injuries, but the only exception is the field of psychology. Psychiatrists don't use brain scans. So he introduced the concept of using brain scans to determine behavioral issues. The second reason why he's very well known in the field is because that's very controversial. There are not a lot of experts in the field of psychology that support it, but nevertheless he is doing it. So it's a really interesting concept. He's very well known because of it, and we're going to listen to him even though we can't see the video tonight. Okay? All right.
In this talk, I'm going to give you the single most important lesson my colleagues and I have learned from looking at 83,000 brains. But first, let me put the lesson into context. I am in the middle of 7 children. Growing up, my father called me a maverick, which to him was not a good thing. In 1972, the Army called my number, and I was trained as an infantry medic, where my love of medicine was born. But since I truly hated the idea of being shot at, or sleeping in the mud, I got myself retrained as an X-ray technician and developed a passion for medical imaging. As our professors used to say, how do you know unless you look? In 1979, when I was a second-year medical student, someone in my family became seriously suicidal, and I took her to see a wonderful psychiatrist. Over time, I realized that if he helped her, which he did, it would not only save her life, but it would also help her children and even her future grandchildren, as they would be shaped by someone who is happier and more stable. I fell in love with psychiatry because I realized it had the potential to change generations of people. In 1991, I went to my first lecture on brain SPECT imaging. SPECT is a nuclear medicine study that looks at blood flow and activity. It looks at how your brain works. SPECT was presented as a tool to help psychiatrists get more information to help their patients. In that one lecture, my 2 professional loves, medical imaging and psychiatry, came together and quite honestly revolutionized my life. Over the next 22 years, my colleagues and I would build the world's largest database of brain scans related to behavior on patients from 93 countries. SPECT basically tells us 3 things about the brain: good activity, too little, or too much. Here is a set of healthy SPECT scans. The image on the left shows the outside surface of the brain, and a healthy scan shows full, even, symmetrical activity. The color is not important, it's the shape that matters. In the image on the right, red equals the areas of high activity, and in a healthy brain, they're typically in the back part of the brain. Here's a healthy scan compared to someone who had 2 strokes. You can see the holes of activity. Here's what Alzheimer's looks like, where the back half of the brain is deteriorating. Did you know that Alzheimer's disease actually starts in the brain 30 to 50 years before you have any symptoms? Here's a scan of traumatic brain injury. Your brain is soft and your skull is really hard. Or drug abuse. The real reason not to use drugs? They damage your brain. Obsessive compulsive disorder, where the front part of the brain typically works too hard so that people cannot turn off their thoughts. And epilepsy, where we frequently see areas of increased activity. In 1992, I went to an all-day conference on brain SPECT imaging. It was amazing and mirrored our own early experience using SPECT in psychiatry. But at that same meeting, researchers started to complain loudly that clinical psychiatrists like me should not be doing scans, that they were only for their research, being a maverick and having clinical experience. I thought that was a really dumb idea. Without imaging, psychiatrists then, and even now, make diagnoses like they did in 1840 when Abraham Lincoln was depressed by talking to people and looking for symptom clusters. Imaging was showing us there was a better way. Did you know that psychiatrists are the only medical specialists that virtually never look at the organ they treat? Think about it. Cardiologists look, neurologists look, orthopedic doctors look, virtually every other medical specialties look, psychiatrists guess. Before imaging, I always felt like I was throwing darts in the dark at my patients and had hurt some of them, which horrified me. There is a reason that most psychiatric medications have black box warnings. Give them to the wrong person and you can precipitate a disaster. Early on, our imaging work taught us many important lessons, such as illnesses like ADHD, anxiety, depression, and addictions are not single or simple disorders in the brain. They all have multiple types. For example, here are 2 patients who have been diagnosed with major depression that had virtually the same symptoms, yet radically different brains. One had really low activity in the brain, the other one had really high activity. How would you ever know what to do for them unless you actually look? Treatment needs to be tailored to individual brains, not clusters of symptoms. Our imaging work also taught us that mild traumatic brain injury was a major cause of psychiatric illness that ruined people's lives, and virtually no one knew about it because they would see psychiatrists for things like temper problems, anxiety, depression, and insomnia, and they would never look, so they would never know. Here's a scan of a 15-year-old boy who fell down a flight of stairs at the age of 3. And even though he was unconscious for only a few minutes, there was nothing mild about the enduring effect that injury had on this boy's life. When I met him at the age of 15, he had just been kicked out of his 3rd residential treatment program for violence. He needed a brain rehabilitation program, not just more medication thrown at him in the dark or behavior therapy, which if you think about it, is really cruel. To put him on a behavior therapy program when behavior is really an expression of the problem, it's not the problem. Researchers have found that undiagnosed brain injuries are a major cause of homelessness, drug and alcohol abuse, depression, panic attacks, ADHD, and suicide. We are in for a pending disaster with the hundreds of thousands of soldiers coming back from Iraq and Afghanistan, and virtually no one is looking at the function of their brain. As we continued our work with SPEC, the criticism grew louder, but so did the lessons. Judges and defense attorneys sought our help to understand criminal behavior. To date, we have scanned over 500 convicted felons, including 90 murderers. Our work taught us that people who do bad things often have troubled brains. That was not a surprise. But what did surprise us was that many of these brains could be rehabilitated. So here's a radical idea. What if we evaluated and treated troubled brains rather than simply warehousing them in toxic, stressful environments? In my experience, we could save tremendous amounts of money by making these people more functional, so when they left prison, they could work, support their families, and pay taxes. Dostoevsky once said, "A society should be judged not by how well it treats its outstanding citizens, but by how it treats its criminals." Instead of just crime and punishment, we should be thinking about crime, evaluation, and treatment. So after 22 years and 83,000 scans, the single most important lesson my colleagues and I have learned is that you can literally change people's brains. And when you do, you change their life. You are not stuck with the brain you have. You can make it better, and we can prove it. My colleagues and I performed the first and largest study on active and retired NFL players, showing high levels of damage in these players at a time when the NFL said they didn't know if playing football caused long-term brain damage. The fact was they didn't want it. That was not a surprise. I think if you get most thoughtful 9-year-olds together and you talk about the brain is soft, about the consistency of soft butter, it's housed in a really hard skull that has many sharp bony ridges, 28 out of 30 9-year-olds would go, probably a bad idea for your life. But what really got us excited was the second part of the study, where we put players on a brain smart program and demonstrated that 80% of them could improve in the areas of blood flow, memory, and mood, that you are not stuck with the brain you have. You can make it better on a brain smart program. How exciting is that? I am so excited. Reversing brain damage is a very exciting new frontier, but the implications are really much wider. Here is the scan of a teenage girl who has ADHD, who is cutting herself, failing in school, and fighting with her parents. When we improved her brain, she went from D's and F's to A's and B's and was much more emotionally stable. Here's a scan of Nancy. Nancy had been diagnosed with dementia, and her doctor told her husband that he should find a home for her because within a year she would not know his name. But on an intensive brain rehabilitation program, Nancy's brain was better, as was her memory. And 4 years later, Nancy still knows her husband's name. Or my favorite story to illustrate this point is Andrew, a 9-year-old boy who attacked a little girl on the baseball field for no particular reason, and at the time was drawing pictures of himself hanging from a tree and shooting other children. Andrew was Columbine, Aurora, and Sandy Hook waiting to happen. Most psychiatrists would have medicated Andrew as they did Eric Harris and the other mass shooters before they committed their awful crimes. But SPECT imaging taught me that I had to look at his brain and not throw darts in the dark at him to understand what he needed. His SPECT scan showed a cyst the size of a golf ball occupying the space of his left temporal lobe. No amount of medication or therapy would have helped Andrew. When the cyst was removed, his behavior completely went back to normal, and he became the sweet, loving boy he always wanted to be. Now, 18 years later, Andrew, who is my nephew, owns his own home, is employed, and pays taxes. Because someone bothered to look at his brain. He has been a better son and will be a better husband, father, and grandfather. When you have the privilege of changing someone's brain, you not only change his or her life, you have the opportunity to change generations to come. I'm Dr. Daniel Lehman.
That was good.
Okay, thoughts?
Right. I enjoyed that. But even before I started school, I didn't know nothing about the brain, but I thought something was wrong with the brain. I know that sounds simple, but I always wondered how the brain worked inside the head.
Mm-hmm.
That's interesting.
How we can recoup the brain. His nephew just removed the cancer. What about the other ones? With medicine, with surgery?
He goes into more detail in another video. I believe he did a combination, once the cyst was removed, of some medication with a change in diet. Other than that, there was no other treatment needed because he went back to normal behavior. Yeah, and I think in the video he actually had a really hard time getting a surgeon to remove the cyst. He talked with multiple doctors. He's a doctor himself, so he knew many, especially well-known doctors, Johns Hopkins, associated with Harvard, Stanford, and all of them declined because they thought it was unwarranted. The reason they thought it was unwarranted to basically perform on this little boy is because simply of behavioral issues. They said, no, it needs to be because of something more physically severe, like a traumatic brain injury or seizures of some sort, etc. So he finally found someone at UCLA who was a really well-known surgeon to perform on him, and the surgeon reported back to Dr. Daniel Lehman saying that it was probably the most aggressive cyst that he has ever seen, that when he removed the cyst, the brain, the skull was as soft as an eggshell when it's supposed to be very firm or really hard. So he said, I wish I had that video. Unfortunately, I can't remember much more than that, but he goes into a lot of detail. He has several books that are bestsellers. I think the New York bestseller for a few years in a row is called Change Your Brain, Change Your Life. He goes into a lot more detail. Yeah, he's really well known. Any other thoughts?
He's right. They should be looking at.
All right, cool. Let's then move forward with Chapter 17, Cross-Cultural Counseling, Engaging Ethnic Diversity. We are looking at this chapter and Chapter 18 tonight. Again, it is not on your final exam. We will be going over what is on your final exam later tonight. We will be taking that next week. All right, but first, let's look. Why does culture matter in substance abuse treatment? 5 major groups in multicultural U.S. society. Differences among cultural, racial, and ethnic groups in use, addiction, and treatment. Substance abuse, not an equal opportunity phenomenon. Treatment providers, racially stratified, and drug wars are racially, culturally, and politically driven. So let's talk about the second real quickly. Differences among cultural, racial, and ethnic groups in use, addiction, and treatment. What do you think that means?
What? Say that again, Dakota?
Differences among cultural, racial, and ethnic groups in use, addiction, and treatment.
It means that there's preferences within each one. In other words, like, if you remember when we read chapter 1, where it was talking about the banning of each particular drug because it was associated with a particular culture,
Okay.
that would be what it's referencing in a sense.
Okay. What else? Differences among cultural, racial, and ethnic groups in use, addiction, and treatment.
I think it has to do with not exposure, being exposed to different areas, and not necessarily an area like a town or street, but being exposed to different areas in the sense of different cultures. Even though you're one culture, you mingle with other cultures as well.
Mm-hmm.
So and the differences in the way you're raised, your traditions,
Okay.
that sort of thing, your religion.
Right, so the differences in the way you were raised, differences in your religion, differences in your culture contribute to differences in motivating them to use substances. So that needs to be taken into consideration when you're assessing a client as well as the treatment. You want to make sure you're tailoring the treatment considering the cultural ramifications, right? We talked a little bit about last week, especially on the quiz, that we want to take cultural influences into consideration when even asking questions. All right, so disparities in use, there are variation within groups. Generalizations lead to erroneous beliefs. Greater acculturation associated with higher use in all groups. So when we talk about generalizations lead to erroneous beliefs, we want to make sure that while we have a general understanding of a culture, to not automatically attribute that assumption to an individual. So if you're, for example, working with a Hispanic client, you want to have a general idea of what the culture is like, but not to automatically assume that culture is what the client believes. So you are then prepared to ask the individual about some of the cultural norms you understand to see if it applies to the client. Does that make sense?
Yes.
Okay, so that way it shows you are competent to the client, that you are not only aware of the cultural norms, but you're being very considerate and asking whether or not those cultural norms apply to him or her. So that way you find some of the client's core beliefs versus erroneous, meaning false beliefs, thinking that, oh, because they're Hispanic, they're not going to like open-ended questions. I'm using that as an example, not saying that's actually indicative of Hispanic culture. That would be an erroneous belief because I'm not actually asking the individual. Very similar to what we heard Dr. Gail Lehman say with catering to the individual, we want to make sure we keep that in mind, right? The balance of having an understanding of the culture, but making sure that the priority is knowing the individual in the context of the culture.
Yeah,
Make sense?
when I look at that, I think about the survey. I think that we as professionals have to do our own survey as far as the people that we are getting to, compared to race, culture, and all that. We may have a general idea of the different races, culture, the highs and the lows, and drinking and addiction, or whatever the case may be, and all that. We can be fair in the way that we treat each individual. As I read this, that's what I gather from reading.
Exactly. Right.
What works for one person may not work for the other.
Exactly. Yes, that's so true. How many times, well, have I seen that? A whole bunch. I can't even begin to describe that each person is unique, and it's the job of the counselor to find that unique formula, behavioral formula to help them function in any environment. It's really, really important to keep that in mind. Right?
Yeah.
Okay. Racial and ethnic issues and substance abuse. Absent from research until 1970, race and culture ignored in the treatment community evolved into the use of ineffective colorblind doctrine. Culturally based approaches still lack empirical support consensus. What does it mean that it has evolved into the use of ineffective colorblind doctrine?
Because they're using the same remedies to try and treat people. And they're also using the same remedies to diagnose people as well. So it's causing issues as far as the success rate as to whether somebody is actually reacting correctly.
Exactly. Perhaps you have a white American individual who does really poorly in treatment because he has a core belief, or his culture, which he believes is true, that going to treatment means he's weak. It's a sign of weakness. That is what you would want to take into consideration, especially if you have other clients from different cultures and backgrounds doing very well with the treatment, and you basically assume that the white American is being resistant or is not compliant. In reality, he has a cultural barrier that we want to really explore.
And I was reading that, as I read the book, I was reading that very often the, what do you call it? I'm going to say newspress, that's not the way the book said it. The way it uses the airways to portray certain cultures or race hinders if you look at that in my own words and not be open to the differences of each culture as you counseling people, it can cause you to be biased in the way that you will treat somebody.
Exactly. That's exactly it. Yeah. Yeah. And you may not even be aware that you are labeling. Right? Okay, so treatment needs and issues for people of color. New paradigms, more research needed. Racial and ethnic groups overrepresented in addiction and treatment. Need strong relationships with counselors. Assume culture and race are always present and operating. Cultural, ethnic, and racial issues may or may not be relevant for clients. Native Americans and Alaskan Natives. 3 million Native Americans in the U.S., 550 federally recognized tribes, extremely diverse, only a third live on reservations, forced relocations, family division, lack of economic opportunity, higher drug and alcohol use than any other population groups. Expectations about use vary with tribes. This is very important. I actually worked with a client who was part of one of the Native American tribes. It was a culture shock for me to learn about the values in the Native American tribe that she attributed, and somewhere in South Florida actually. It was really, really common for 13-year-olds, 14-year-olds to begin drinking. The sexual abuse was actually really, really high in that society. It was really unfortunate. And because her tribe was federally funded by the government, because of them being driven off their land, as a way to be compensated for being driven off their land, a lot of money was at their disposal. So even though they struggled with a lot of substance abuse and a lot of dysfunction, the fuel that was added to the fire basically was the money. They had an unlimited amount of, almost like an unlimited amount of resources, like $10,000 a month that was given as a stipend. So it really exacerbated the substance abuse. So, and it really is more common in South Florida than you think. At least that was more than I All right, treatment for Native American and Alaskan Native clients, considerations, cultural stereotypes, chronic historic trauma, distrust, institutional racism, collectivism, human interrelatedness with nature, respect for spiritual and elder wisdom, emphasis on youth. So skills that we want to try and help them with include extend kin, integrate spirituality, understand the importance of communalism to recovery, collaboration, not confrontation, ceremony and spiritual renewal. Studies are sparse, identifying successful treatments. Questions? Okay. Let's look at Asian Americans, Pacific Islanders, extremely diverse cultural racial group, 14 million, growing quickly, significantly different use patterns among subgroups, absence of enzymes affects metabolism of alcohol, so face flushing, nausea, and headache occurs in 47 to 85% of Asian people. You will find with Asian people, Asian Americans especially, that alcoholism is actually not very common. Substance abuse is a different story, but alcoholism, very uncommon. That's because alcohol has a significant impact, negative impact on Asian Americans. So it doesn't work well with their body at all. Nausea and headaches are very frequent. Treatment for Asian American clients, considerations, so language barriers, stigma of seeking help, treatments as forceful acculturation, family hierarchy, emotional restraint, avoidance of shame, social harmony, skills, collaborate with ethnic organizations, psychoeducational groups, and provide for anonymity online groups.
What does it mean by treatment as forceful acculturation?
So treatment as forceful acculturation means that if they are required to attend treatment, that it is against their belief system and it's a way of becoming more American.
Oh.
Shame is a big factor in the Asian American community. When you are forced to ask for help, for example, legally required to seek treatment, it is very shameful, not only to the individual, but to family. And that is seen as the ultimate slap in the face, so to speak. Latinos, largest and fastest growing ethnic minority in U.S., subculture heritage, Cuban, Mexican, Puerto Rican, South Central American, greater within than between group differences, higher prevalence of drug use other than alcohol among young Latinos, alcohol use by Mexican Americans may be higher than subgroups. So treatment of Latino clients, considerations, language barriers, power of Latino family, racism and discrimination, survival skills, distrust of white culture, social centric, gender hierarchy. So the skills we want to try and help develop include involving the whole family, groups, psychoeducational, integrate client spiritual, cultural, and family values, supportive confrontation, honesty and expression of emotion. What do you think supportive confrontation looks like versus general confrontation?
Supportive confrontation is when you tactfully approach the issue that they're having without making them feel guilty. I don't know, what I see, let me change the way you look at this. So that would, to me, that would be confrontation.
Okay.
Kind of like motivational interviews, huh?
Okay, so perhaps motivational interviewing, perhaps what you just mentioned. It really comes down to the individual. So it really helps to understand the culture of what support looks like, including the family, making sure we're showing positive regard, using a lot of words that indicate respect, since respect and power in the family hierarchy in Latino family is very big. And at the end of the day, once learning about the general culture, you want to find out what it means to the individual, what the support look like for your client. So even having a conversation about what support looks like for him or her can be really helpful for you as their therapist to support him or her in the therapy process. Really comes down to the individual. But again, using those skills, motivational interviewing and using respect and asking what it means to them. African Americans, 39 million of U.S. population, cultural upheaval of slavery, continued disparities in education, healthcare, employment, and financial services, targeted for liquor and tobacco advertising, disproportionate rates of violence and health difficulties. Let's talk about targeted for liquor and tobacco advertising. What do you think that means?
Liquor and tobacco companies target their culture. They find ways to market to it. It makes it appealing.
Okay. Why African Americans versus any other culture, you think, according to the reading?
I think the personality.
It comes back to their historical culture being, according to the book, being raised in, unfortunately, in slavery, in fields. Tobacco usage was very common. And so historically, in that culture, it's much more widely accepted. So as a way to market, they target African Americans. It's really important to remember, especially when you're dealing with treatment. You want to take location into consideration when discussing treatment approaches with your clients. Let them know that, hey, listen, you may be targeted more so than other cultures or even individuals because of maybe where you live or because of the color of your skin. It's really important to know that.
That's another cultural bias as well. Sort of like, I can't find the word because the word I have in my head is not the right word. So
Okay. So treatment of African American clients, considerations, racism, distrust of white culture, different beliefs and attitudes about health, more external stressors, possible internalized negative self-images, womanist feminist theories. So skills, life skills training, integrate religion, spirituality, involve family, friends, religious leaders, staff of color, share own recovery experiences. So when we talk about life skills training, what do you think that means?
Programs that help them understand prospectively where they're at. Like I went to a life skills training. It talks about, how to, first of all, to understand how your brain works. It talks about, the composition of the brain, what certain things do in the brain, how drug and alcohol use affects certain parts of the brain, behaviorally or behavioral-wise, what those things tend to do and how they tend to either keep you down or tend to accentuate certain areas. But the life skills training in and of itself is just a training to help you get by certain difficulties in your life and understand how they work and how to tackle them.
Yeah, so some of the concrete difficulties that you might learn in a life skills class include balancing a checkbook, knowing how to cook for yourself, making sure you understand how the mail system works, how to mail letters, how to apply for jobs, how to create resumes, how to really get along in life regarding basic needs. So those are life skill training classes typically. So racial and cultural identity models, race as a psychological, not demographic variable, racial identity, a lifelong dynamic process, reflects attitudes and behaviors of internalized racism. For whites, identifying and moving away from racism, racial identity status related to treatment motivation and retention and study of African American clients. Multicultural counseling competencies, 3 domains. Counselor awareness of own cultural values and biases, as we discussed a little bit earlier. 2, counselor awareness of clients' worldview. And 3, culturally appropriate intervention strategies. Within each 3 sub-skills, beliefs and attitudes, knowledge, skills. This goes back to what we were discussing briefly last week. It's really important to understand yourself, understand not only your core beliefs, but also your cultural beliefs. If you are African American, Hispanic, white American, any of those, you want to make sure you understand your worldview, your core beliefs. That way, you can be aware of how you may interact with differing worldviews. You may be more aware and in tune with a client's worldview as a result. One's own cultural work. Effective counseling requires awareness of one's own cultural attitudes. So mature psychosocial identity necessary, integrates self-awareness and awareness of racism, sexism, and poverty. Challenge own assumptions that may hinder work. Values both the individual difference and collective cultures. Improves delivery of services, continuity of treatment, and success rates. What do you think it means by values both individual differences and collective cultures?
It means to value what a person thinks about or how they react differently. I mean, as an individual.
Mm-hmm.
And then in the collective cultures, meaning that how the cultures themselves react to society as a whole.
Okay, yes. Yeah, absolutely. That's a good way of looking at it. It's really about that balance. Making sure you acknowledge the individual differences from the general culture, but seeing how the two interact. Finding effective strategies for a client's worldview. Counselors must work outside of counseling sessions to educate themselves about groups with which they work. 2, learn about cultural and institutional barriers to treatment. And 3, educate clients and community to eliminate biases. Again, this does require work that you may not learn in here. Here we begin the discussion, but when you are in the field working with the client, it then falls on your shoulders to research, find out more regarding whatever worldview and culture your client comes from. That way you can be more effective, be aware of their worldview relative to your worldview, and hopefully eliminate biases as a result.
Well, you know, when I went to recovery for my papers,
Yes.
I noticed something extraordinary about it. You didn't even feel no way that you was different. They had this ability to subside and be unrestrained in their biases. But they were supportive without being supportive. It's like they were programmed. Even though they wasn't programmed, but they valued life period around everybody, and they carried it like that. You didn't feel any. So I learned by going to these sessions that it's definitely possible, but it's definitely necessary, because our thinking in our own social, cultural persona can really affect someone in a very, very negative way. It can be detrimental, because with the way that they were, it helped you to be able to just rest and relax in that attitude, and that is definitely necessary.
Yeah. I'm glad you had positive experiences resting and relaxing in that attitude. What do you think?
Professor, the thing is, for instance, Haitian guy came to the United States when he was a little boy.
Okay.
And he comes to our office, and he lived here in the United States since 5 years old. How his culture, because he was 5, probably he's more American than Haitian. How I can relate his background with him in this situation?
That's a really good question. Did everyone hear that scenario? Basically, you're working with a client who was born, correct me if I'm wrong, born in Haiti, but moved here when he was
5 years old.
And has been here ever since. How do you go about with that client regarding cultural values? What do you think, based off of the presentation, maybe what you've read so far in the book, how would you go about that as a Christian clinician?
To help him.
How would you go about that? How are you taking the worldview and cultural considerations?
In his behavior, probably. Because, I don't know if they help him with the Haitian thing. Because for me, in my opinion, he's more American. Because he grew up in schools, around American boys,
Okay.
and how the culture, I need to know his culture to help him.
Okay.
If he's still with his parents,
Yeah.
they brought a lot of their traditions and cultures with him, even though they're in America.
Okay. Perhaps parents brought the cultural considerations with them.
Yeah, and then on top of that, he's in American school. If he was at 5 years old, that means that he became American in a lot of ways that his parents weren't.
Okay.
Because of going to school, being around American children.
Okay. It's possible the client has a family that is rooted in the Haitian culture, but has friends rooted in the American culture.
Yeah.
That's possible. How do you know if that's the case or not?
Find out in the sessions.
Yes! You find out in the sessions. You take the individual into consideration. First and foremost, don't make any assumptions. It's really hard to do, but I believe once you're more self-aware about your core beliefs and even your culture, making assumptions will become less automatic. One is to never make assumptions. That way, you don't raise any defenses and hopefully eliminate any biases. So once you, one, don't make any assumptions, two, you research a little bit about the culture. Hey, I'm looking at your intake. You were born in Haiti. You were there until you were 5 years old. You've been here ever since. Tell me, what was that like for you? Oh, well, perhaps the client says, I was too young to remember anything about Haiti. We haven't been there since. My parents go once every few years. Or perhaps he says, oh, although I don't remember it because I was so young, we go back every single year with my family, and it's a big part of who I am. A lot of my family is there. I have perhaps a lot of cousins, aunts, uncles who live there. It's a really big part of my life. And then, based on your research, knowing a little bit about the Haitian culture, you can ask some open-ended questions. Well, tell me, what is your spiritual life like? I know a little bit that X, Y, and Z is very common in Haiti. Is that what you identify with, or does your family or anyone else, etc.? How does that impact? Exactly. So using some of that information that you research outside of the session right, exactly. And the great part about all of the research you do outside of a session accumulates. For example, perhaps you have worked with a client for the very first time from the Hispanic community, so you do a lot of research outside of the session. It's not going to go wasted, or it's not going to strictly benefit only that client, because perhaps you get a few more Hispanic clients down the road where you can use some of the information that you learned and researched with future clients. So it really doesn't go wasted, but again, it starts with not making any assumptions, and then to moving towards that informed questioning. You're informed about the culture, but you're also questioning the individual regarding the culture. Yes, absolutely, and that really comes down to motivational interviewing, Associate for Multicultural Counseling. The reason why I say it really comes down to these two is because a lot of the techniques we are learning here generally carry over and relate to this chapter. It's also why I'm not really going to include it on the test. This chapter really overlaps with a lot of the discussions we've had. For example, motivational interviewing, positive regard for a client, making sure you're self-aware of your core beliefs and cultural values. This is what we have discussed already, maybe not in as much detail as this chapter. Again, best practice will take all of these factors into consideration. For example, we've read or just talked about taking the family into consideration, supportive confrontation, collaboration versus confrontation, again, a lot of best practices will follow suit regarding these cultural differences, which is good for us. Right? We want to use descriptions and observations versus labels and judgments. We want to take a non-judgmental approach. We want to help them develop life skills. We want to help them be more collaborative in the process versus the counselor being the lead. So it really comes down to that. All right, it's 8 o'clock. Take 15 minutes. Come back 8:15, and we'll begin chapter 18. Okay? And then we'll go over the final exam.
8 o'clock already?
8 o'clock already. Pause.
Well, I'll go.
Photoshop is, I mean, you can get the portable, but it's not gonna do a regular Photoshop.
Okay. Chapter 18, Gender, Sex, and Addictions. Definitions. Gender refers to one's identity on the spectrum of female to male. Sex refers to the physical anatomy of a person. A transgender person is one who experiences discomfort within the conventional expectation of his or her sex. So the first term, gender, is on a spectrum where more likely wherever you work if you are in a non-Christian setting. So it's a spectrum because of what has ruled on the DSM-5. It is more fluid versus concrete, black and white, of male or female. So while that is true for non-Christian, for residential treatment centers that are not Christian oriented, you will find that in a Christian setting, you again do have that flexibility to treat it a little bit more concretely, but again, it will at the end of the day be based on your client. So transgender person, I also want to point out, experiences discomfort is the key word here. So if they experience discomfort, then they qualify for transgenderism, whereas if they do not experience discomfort, identifying with the opposite sex, then that is not grounds for a disorder. Does that make sense?
No.
I have a question because
Okay.
I've always been confused because to me they sound really similar. What's the difference between gender dysphoria and a person who's trans? Because I think that gender
Can I answer
dysphoria.
that?
Okay, what do you think?
Up until the DSM-2, transgender dysphoria, what is it called?
Gender dysphoria?
Dysphoria, yeah. Okay, was actually homosexual dysphoria. Because homosexuality until DSM-2 was considered a dysfunction. It was considered an abnormality.
Okay.
So then to ease the tensions with the gay community, because it was just more accepted, they removed it from the DSM and made it transgender dysphoria. And then they even took that out, because if you look at the DSM-5, transgender dysphoria is not there.
So the difference between transgenderism and gender dysphoria is the discomfort.
Okay.
So the client is basically uncomfortable with identifying as opposite sex. They're very torn between what sex to identify with, and that is gender dysphoria. If they're comfortable, experience no discomfort at all identifying with the opposite sex, then that's when they are labeled a transgendered individual.
Okay.
Does that make sense?
Yeah.
But that's kind of odd, right? They removed a lot of the definitions for homosexuality and transgender out of the DSM.
Yeah. Yeah, there's been a lot of changes over the DSMs. So more definitions. One who is transsexual feels that his or her gender identity does not match his or her sex. And a person who identifies as intersex possesses a mixture of anatomical features typically identified as male and female. So that's someone born with both genitalia, which does happen, although rarely. So gender, alcohol, and drug use and abuse in the U.S. Alcohol was consumed by men, women, and children in colonial times. Harriet Martune, in 1830s, 4 reasons why women might drink. Cultural oppression. What is that? Vacuousness? I don't remember what that even means. Okay. Self-medication and prescribed medication. Led to cultural criticism of women drinkers. So again, looking back more than 100 years, some of the factors to take into consideration. Temperance movement, use and abuse in the U.S., late 1880s. Increase of morality and religious influence. The moralization of alcohol use became ingrained in societal thinking. Virtue and masculinity. The relationship between gender and drug use is complex, driven by cultural impressions and moral thinking. This does relate back to the very beginning of the semester about how alcohol had a lot of cultural
Vacuousness means emptied of or lacking content.
Oh, perfect. Thank you. Okay. So lacking content. And a little bit of review here, but not too much. Gender and addictions, no one effective method of treatment for all clients. Again, very similar to probably in the first chapter we read. Taking more of an eclectic approach is probably the most effective. Women's issues largely neglected in literature. Only 29 studies on women alcoholics between 1929 and 1970. It's a man's problem. Focus now shifted to illicit drugs. Women's use today, 6.5% of women aged 12 years or older use illicit drugs. 47.1% of women of the same age range identify as current drinkers. Women's use or abuse of prescription drugs equals or exceeds that of men. Not me.
Oh, that thing.
10.4% men versus 5.7% of women aged 12% or age 12 or more have or are addicted to substances. Age is 12 to 17, rates are the same, equal in use of stimulants. Men use more marijuana, opiates, inhalants. Sex is now equal in early drinking behavior. So we're seeing a shift towards more equality regarding some of the use. Men used to have more exposure to some of the substances, whereas now we're seeing women's use increase. Women and alcohol, biological considerations. Women metabolize differently. Intoxicated after consuming half as much as men. Develop cirrhosis of liver more quickly. Women begin drinking later, drink smaller quantities. And telescoping. Time between drinking and onset of problems is shorter than that of men. So it's really important to remember how drinking affects the person on an individual level, but also as in a general setting that it can really impact based on your sex.
Telescoping, that's the thing that you know,
Yes.
I think I went back and reread it on biological consideration. And it was talking about this phenomenon is kind of referred to as just starting at not at the beginning as telescoping. Telescoping occurred in part because women's bodies have a higher fat to water ratio than men's.
Exactly.
So
Again, part of the biological makeup that really predisposes women more to drinking than men. It's important to remember that.
yeah, I never thought of that right there.
Let me ask you this. How might that information, telescoping, for example, women being more biologically predisposed than men, really impact the way you counsel a female client in substance abuse versus a male client struggling with substance abuse?
Wow, that's a question.
Actually, informative about a little bit of psychoeducation there.
Okay, psychoeducation. What would you say specifically?
You're biologically predisposed.
Okay, you absolutely could say it just like that. When would you say that?
Not in the beginning, that's for sure.
Probably when you're talking about specific usage, how much the client drank. The client could say, well, my husband or friend who happens to be a guy drinks twice as much as I do, and I don't get as wasted as he does because of that. Well, we might want to, at that point, introduce some psychoeducation saying, listen, first we take it on an individual basis and taking into consideration that you are female. Females are more biologically predisposed to be intoxicated more quickly. Intoxicated after consuming half as much as men. So again, taking that individual into consideration can be a great way to help keep them accountable, understand more about themselves, increase that awareness. Yeah, in that way. All right. Women and drug use, biological considerations, health risks specific to women, risk of death, malnourishment, hypertension, sexually transmitted diseases. Younger women, accidental death or injury, suicide, overdose, middle-aged women, breast cancer, osteoporosis, and older women, fractures due to accidents. Again, just in different ways how substances impact women versus men. Hormones and addiction, significant role in development of addiction and relapse. Menstrual cycle, pre-ovulation, stronger effects from stimulants, and post-ovulation, enhanced effects from alcohol and nicotine. Interesting to know.
Advantage.
I think that has to do with the fact that we are child bearers and have menstrual cycles.
Mm-hmm.
That makes us more susceptible to these things because our body, the way it functions.
Absolutely. Yeah. Oh, yeah. It's really good to know this information, too, when looking at the triggers. When a client is triggered, when a client maybe is triggered earlier in the month versus later in the month, really to keep that in mind. All right, psychological considerations for addicted women. Every DSM diagnosis more common in addicted women than men. Anxiety and depression more likely than men to have affective disorder prior to addiction. Women may need more treatment post-addiction. Suicide and alcoholic women are 5 times more likely to attempt suicide. Death rate equal to men.
Wow.
What do you think?
Wow.
Because we are in motion.
Yeah, everything's
Totally
linked to
emotion.
emotion. So.
Biological considerations too.
Yeah,
Yeah.
it's a lot of difference.
My goodness, that.
And I also read in one of my psychotherapy books, well, one I have, that the women, when they do attempt suicide, they attempt like less violent tactics than males, because they males use guns and women use like pills and things like that.
Mm-hmm.
Quiet thing, gas and everything, yeah.
Yep, no, just
When would this information be really useful in a therapy session?
definitely at the point where you have not just a psychologist, but when you have the psychotherapist and the all the people that are in place to help you. I think you would need more than one type of. I think about 5 or 6 of them that have different labels to be able to help bring that forward to a person.
Okay.
Psychiatrist, psychotherapist, they have the nurse, they have the neurologist, different ones. I don't remember all the names, but I read it.
Would you communicate that information to the team?
Yeah,
Okay.
because each one specializes in a different way, and all of them together can make because you got the psychoeducational psychotherapist, and you have the neurologist. I'm trying to be smart now. But anyway, all of those together, you make a whole, and you can consult one another how to talk to that person as a whole.
Okay, so yeah, this could be really important information to present to the team. You want to work on a team, you want to make sure you're collaborating with that team, and especially when you're looking at discharge. You want to set your client up for success. You want to have a very specific plan in place. A really helpful plan could include some of this information. Hey, listen, you are more likely to, for example, like in your suicidal example, they tend to be more nonviolent approaches versus violent approaches. In a safety plan, you can include, hey, make sure as a way to remain safe to avoid X, Y, and Z. Hey, as a way to maintain safety, let's make sure that we're keeping an eye out for all of these biological considerations due to the client being a female or a male. Really
Would you
important to
put that
know.
in a flyer? I mean, not a flyer, but, could you put that in your,
Contract in the end, no contract.
In a report.
yeah, I mean,
Mhm. Yeah, you can, in a report, you can say the client and therapist discuss these factors and making sure that whatever safety plan you do create includes some of the information. Yeah. So, social considerations for addicted women. Women's problem drinking linked to relationships. Greater risk with family history of addiction. More susceptible to social pressures. Substance abusing partner more likely. High drinking out of guilt and shame. And those entering treatment have less family support, lower SES, education, unemployed. Addicted women who parent. Babies at risk during pregnancy, fetal alcohol syndrome, fear of losing children to social services if they seek treatment, lack of childcare is a barrier to treatment. Remember to take that into consideration when part of an intervention or even during the first few
Yes.
therapy sessions.
Can this happen? Can they lose their child if they're seeking treatment?
Yeah, depending on the situation, it's possible.
Oh,
Yeah, depending on how severe the addiction is. They can.
and percentage of children, even though they can be normal, the fact that their parent have this addiction, whatever across the board they may have, it can cause the child to become
Mm-hmm.
mentally, have a mental disorder.
Mm-hmm.
More than one can become comorbid.
Right,
So,
right.
yeah.
All right, women, addiction and violence. Men are sexually aggressive to women who drink. Women's use of alcohol also increases risk of non-sexual violence. Relationship between addiction and violence. Bi-directional, addicted women more likely to be victimized by partners. Sexual assault far higher among addicted women. Why do you think that might be the case?
I think women are more aggressive. And I think those women that are into the scene of a lot of alcoholism or drug use are more aggressive.
and men also take advantage of this, like if they're drunk, if they're intoxicated, they'll take advantage of the situation.
Right, okay. So it makes the women more vulnerable. If a man or a predator sees that a woman is intoxicated, vulnerable, inebriated, irrational, it really makes it, unfortunately, easier for a predator to take advantage of a woman in that situation.
Right.
It also suggests that, was it on the last slide? Women who struggle with addiction tend to surround themselves with other individuals who also struggle with addiction.
Mm-hmm.
So if you have a man struggling with addiction and women struggling with addiction, what happens when, let's say, both are heavily intoxicated? What decreases? Starts with an I. Inhibitions.
Oh,
So the man becomes a lot more forward, the woman becomes a lot more vulnerable, and it can be a really unfortunate situation. So it's just really important to remember that.
Mm-hmm.
All right, moving into tobacco use. Tobacco kills far more than drugs or alcohol each year. More women than men smoke.
Wow, I did not know that.
I never. Okay.
Partly because it's more difficult for women to stop smoking. Cancer of the cervix, heart disease, used during pregnancy, linked to spontaneous abortion, premature birth, low birth weight, infants' behavior problems. Really unfortunate, and that's why we see a lot of tobacco commercials.
Not
Back-
anymore. Back in
Yeah,
10
back
years
in the
ago?
day, yeah, you would see a lot of tobacco commercials
Yeah.
because a lot of research has discovered tobacco really, really hurts women, particularly children.
I had a dream, always I had a dream that I was smoking. I never smoked.
Hmm.
I always dream. I run and then I sit down and then I smoke.
Wow.
I never smoked. My father, third generation of Christian,
Hmm.
never smoked.
It's interesting.
And I was reading that their smoking related to their menstrual cycle,
Mm-hmm.
and also that they have less support groups for women. They have, like men have more support groups because we automatically think of the man as the big smoker.
Right. Again, taking into consideration the culture, perhaps there are cultural norms that are barriers for women getting help, especially regarding tobacco and a lot of other issues. Yeah. Men and addiction, biological considerations now for the guys, physical effects of heavy chronic drinking, increased heart problems, stroke, and high blood pressure. Men with family history are more susceptible, ADHD and cocaine abuse typically linked. Again, this is a review of a lot already of what we discussed. That's, again, one of the reasons why I'm not requiring you to necessarily read the whole chapter. You're not being tested on this chapter or the previous chapter. We've already seen, for example, the second point, how family history really predisposes you because of the biological link to become addicted. We really want to make sure we don't lose sight of that. All right, men and addiction, psychological considerations may use to stimulate or suppress feelings. Men more likely to exhibit sociopathology, engage in criminal behavior, tend to externalize, blame others, and aggressive boys more likely to abuse than non-aggressive peers. Men in addiction, social considerations, more likely to use drugs to socialize. Problem use tends to show earlier, more legal problems, violence more likely for men when intoxicated. Support for treatment more likely, family and court system. Treatment, Minnesota model. Since 1940, 95% of programs based on this model. It's residential, now more outpatient with education and 12-step meetings. Emphasis on character and spirituality of clients. Fails to meet unique needs of women.
This is a one-dimensional model, that's why.
Yeah.
That's the answer. It's a one-dimensional model.
And that's also why it's important for counselors to be aware of all the different theories that contribute to people using substances. We want to be aware of all the various treatment approaches that we can use as a result. So if there's a biological component, maybe it's family stemming from a family system issue, perhaps it's more cognitive behavioral, that really informs your type of treatment, even though the treatment facility or the residential facility or the private practice or the outpatient setting or the intensive outpatient setting, whatever place you work, may only promulgate one-dimensional type of thinking. You as a counselor have the opportunity to expand the horizon, to really use a lot of different approaches to treat your clients. It's really important to remember that. All right. Women's responses to treatment, Minnesota model paired with 12-step practices, not effective for women, hierarchical, confrontational, non-mutual, focus on individual pathology, ignores social context, sexism. Power for some women, already in short supply. Mixed gender group treatment, less effective, but some benefits also. Women-only groups, safer place for sexually abused women, often other services connected, childcare, health. It really depends on the place where you work. Some places have co-ed, some are strictly one sex versus the other for a lot of different reasons. The research is pretty mixed on that. Women's treatment needs, counselor-client relationship key, individual counseling, collaborate, facilitate freedom to choose success, same-sex counselor option, cultural match. Oftentimes you will see this same-sex counselor for a lot of different reasons. That's more common than, again, it really comes down to the individual though. Topics for women's treatment, strength building, gender issues, problems in societal context, overcoming disadvantage, understanding oppression and advocacy, incest, sexual assault or sexual abuse, general and reproductive health, childcare, parenting, cutting-edge therapies, yoga, meditation, mindfulness, music, art therapy, acupuncture, again, trying to expand the horizon of treatment approaches, as you will see more in the future. We saw that in the video earlier tonight. We're possibly going to be looking at brain scans in the future. It's possible that we're going to be looking at amino acid therapy in place of chemical therapy, or what we know as medication, because, again, medication could be the client's substance of choice. We want to find alternatives. If amino acid therapy, if brain scans are not available, there's also, as we see, acupuncture, yoga, mindfulness, meditation, looking for more holistic approaches to help the clients recover. Men-specific treatment needs. Men outnumber women in treatment 4-to-1. Traditional counseling may initially be counterproductive. Goal setting, creating lists, homework assignments, and creating contracts. Address sense of counseling as a masculine, focus on concrete concerns beyond addiction alone. Help men feel safer to delve into deeper issues. So really, really common to find more men than women in treatment settings, especially regarding substance abuse. It's also really important to remember that even though there are a lot of men there, it can be really unmasculine to be there. So again, just a factor to take into consideration. Other factors specific to men, these may contribute to positive outcomes: health, education, anger management skill training, social skills training, recreational and leisure opportunity development. Men are more often mandated, court-ordered clients. Transgender clients, dearth of research, lumped with LGBT community. Counselors need to understand this population's issues with discrimination. World Professional Association for Transgender Health Standards of Care. Intersex clients, little literature. Intersex clients' resilience is likely. Counselors are encouraged to seek specific training. Regarding transgender and intersex clients, there is a lot more research being done more recently. That is because of the LGBTQ movement. There is a lot of focus on it. So we should be seeing probably in the next 5 to 10 years a lot more results regarding these populations and substance abuse.
I went to one meeting they have.
Oh, okay. Yeah. Yes. Yes.
They do.
Treatment outcomes. Women more likely to drop out or relapse than men. Men more likely to enter treatment due to family, opposition, or court order. Men were more likely to return to treatment following pressure from social institutions. Women were more likely to re-enter at the encouragement of a social worker or a counselor. Why is this information important to know?
Because we're prospective counselors.
Yeah, what if I am a previous client, I relapse?
Oh.
And I don't want to go back to treatment. The way you approach me or intervene is going to be more effective based on this information. So if I'm a woman, I'm more likely to go back to treatment, even though I'm initially resistant, if you encourage me as a social worker or counselor. I'm less likely as a man to go back to treatment because you're encouraging me. If I'm a man, you get my boss, and you put pressure on me from a social institutional perspective. That's more likely for a man to go back into treatment versus a woman.
Listen, man, go back into rehab and you'll get locked up.
So if you ever are a part of an intervention, or if a family or parents, for example, seek advice from you as a counselor, listen, we found out that even though Danny loved you as his therapist, 6 months down the road, he was able to stay clean, but he relapsed and he's too embarrassed to come back. He doesn't want to go back into treatment. He doesn't want to see you again. What do you suggest? Well, does Danny have a job? Does Danny have a boss? Okay, let's talk to the boss. Let's make sure we can get some type of pressure from a social institution perspective that might be able to help him get back here, versus a woman might be a different approach. Useful websites, Women for Sobriety. Questions? All right, so I did go through these 2 chapters quickly for a reason. Again, a lot of it is review, and it's not going to be on your final exam. So I don't want to spend too much time on it. I want to spend our time wisely. I want to make sure you use the rest of the time tonight to talk about the final exam and then go study for the final exam. So the first topic I am going to announce about the final exam is that it will be online. You will not be required to come here next week. I took a look at the final exam schedule, and there are a lot more final exams for some reason this semester more than any other previous semester. So I don't know how many of you have different classes, how many other classes that you are studying for, so you will have flexibility with the final exam. You can take it from home. You don't have to come here on Wednesday, and you can take it from home any day, Monday through Friday. So if you're really busy studying for, let's say, 3 other exams, and those exams are Monday, Tuesday, and Thursday, that's fine. You can take the exam Friday. You can have the whole week to study, or if you want to get it out of the way first, you can take it on Monday, but you'll have Monday through Friday. Please study for the final exam. It will be open note, open book, but it will be timed, and it's really because it's open book, open note, going to test your conceptual understanding. I'm not strictly looking for memorization. I'm not strictly looking for reiteration. I'm looking for conceptual understanding, that you understand the concepts. I may be giving you case studies. I may be giving you stories, so to speak, to analyze and really think critically using the skills we discussed. So please review the skills that we have discussed so that you can use them quickly and correctly on the exam. You'll probably, I haven't fully decided yet, it's probably going to be either a 2-hour time limit or a 2.5-hour time limit. It really depends on how I finish the rest of the final. I haven't finished writing the final, but what I have written so far really tests your conceptual understanding. You will have some true and false, you will have some multiple choice, but you will have that critical component of looking at a scenario, for example, maybe a client or a case study from your textbook, that if you write your textbook, you will be able to recognize and really being able to assess it properly using a lot of the factors we discussed in class.
What time we have to have it in Friday by?
The time limit, I think, is by midnight. So you basically have from Monday midnight to Friday midnight. So you can even begin the exam at 11:59 p.m. and then you'll have that 2.5 hours till like 2:30 in the morning or 2:29 in the morning to finish it. So
Chapters.
I wouldn't wait until that late. I don't want you to risk not taking it.
Always whipping.
Yeah, because I am allowing a lot of flexibility. If you miss it, you miss it. I'm not allowing you to make it up because you have 5 days to take it, and it's from the convenience of home. It's a lot more flexible than having to be here Wednesday at a particular day and time.
Okay.
So
Much
please
appreciated.
be cautious.
It's going to be the chapter.
Chapters.
You
Okay.
can go over the review right now.
Yes. So let's take a look here. Let me see if it will all come up. Let me see if I can link it to.
And the last quiz.
Quiz 5?
Say again.
The last quiz.
Quiz 5, did you grade it?
Did you grade
Yes.
it? Yeah, I know you did it, but you
Or
didn't
did
read it.
did you guys access the answer key? Do you have access to an answer key that was uploaded?
I didn't.
No, I didn't.
Check to see there should be an answer key where you can access quiz 5 and what ideal answers would look like. Basically, if you did very well, I think majority of you all did well on the quiz. So if you got 100%, just know that your understanding of it is accurate. Okay, let's see.
I don't know what I got. Did you post a grade?
You did.
It should be posted, yeah, on Popular. It should be uploaded.
Would it say quiz 5?
Where exactly?
And there's still where, yeah.
Assignments.
So if you click on quiz 5,
So
Under-
quiz 4.
Go to test.
Oh, quiz 5, and then it's gonna give the answer key.
Oh,
and it
says
should be available
Okay.
right under your name.
I only have quiz 4.
Yeah.
I'm not sure exactly what it looks like on your end, but when I have it on my end, I click on quiz 5, it has everyone's name and grade. When I click on your name, then it has the,
Okay.
I only have
The
quiz,
file.
quiz 4. I don't see
Mine
quiz
doesn't
5.
show quiz 5.
We need it.
yeah, it should be. Let me double check. Let me log in. Yeah, do you mind?
It says quiz 4.
I'm gonna see what it looks like in your end. Oh, I don't see it.
Yeah.
Hmm.
I saw one.
You see yours?
Mm-hmm.
Yours is on your page?
Yep.
Let me see mine on my page.
Assignments.
Weird. Let me double check. I'm sorry.
No problem.
There you go.
Thank you.
So I'm getting really slow internet in here.
Yeah.
I will go back to my computer tonight and make sure everyone at least has access to your grade on quiz 5 and the answer key to quiz 5.
Okay.
I will double check that. Yeah, the internet's so slow in here. Let me try
Since this afternoon.
Chrome.
I only have 3 or 4 also. I don't have 5. So we studied quiz 3, 4, and 5.
Not just the quizzes. You have to review it.
Yeah, well,
You will need the.
Yeah, unfortunately I'm not able to even look
yeah,
because it's not even responding.
okay.
The Wi-Fi, I don't know why the Wi-Fi is not good on this side.
3, 4, and 5.
Do you mind if I see your phone one more time?
Oh, this is
Or whichever, yeah, I wanted to see the quiz. I'm gonna look underneath there.
No, 1 and 2 is not on there, but we don't need 1 and 2, do we?
No,
No, we're gonna ask you the-
midterm.
There you go.
Correct. Basically, okay, thank you.
Check 4 and 5. Because those are the loud ones.
All right, got it.
Yes.
Oh, no, just
Okay.
I'm trying to relax from a long day. But I'm falling asleep.
The last one was quiz 5.
It's not on our page.
Okay, so what I will do, thank you.
Well,
I can't see it.
No.
Okay.
Yeah, okay.
Okay.
So I will double check and make sure everyone has access to quiz 5, the answer key. And since I'm not even able to pull up the syllabus, I will make a document outlining all the chapters very similar to what I did for the midterm exam of what chapters you want to make sure you review, any articles that we discussed to review, and then of course the quizzes, any of the quizzes after the midterm. Very similar to the midterm exam, if you review your quizzes, and when I mean review your quizzes, not just memorize the answer to the quizzes, but understand the material, the content of the questions, you should do very well. Again, a lot of what we've discussed on the quizzes is going to be tested by you, but not in the same way. So they're not going to be repeat true and false questions, but they're going to really look for conceptual understanding of the same content. Okay? Does that make sense?
Yeah.
Okay. All right. Any other questions?
No, you're gonna put it on the board for us.
I'm going to put it on the board for you so that way you have at least all the chapters outlined, all the articles, and then of course the quizzes. Other than that, have a good winter break, and we'll see you next week. So that way, again, you'll have some flexibility. I wish you all well with any other finals that you have to take next week. But until then, Merry Christmas, Happy New Year, guys, and if you're taking statistics, I'll see you in the spring.
I need to start studying yesterday.
Are you in statistics? No.
No.
Okay.
No, that would be just,
Yeah, I'll see you then at the
that
spring.
would be this guy right here.
Okay, thank you all so much.
Thank you.
Thank you. And you'll also get your grades within the next week or two regarding the 3 reflection papers.
Yes.
Okay? Thank you guys. Thank you.
Are you going to
You
give
all have
another
grades.
class instead, or
What's it?
like statistics, and you're gonna give another class or no? Just statistics.
I
and
am only teaching stats next semester.
But the next semester.
The semester after that,
Uh-huh.
I believe I'm teaching an elective in the summer. But I don't know
Who are you
which one.
teaching?
I'm not sure. That one they haven't told me. I know I'm basically teaching every fall this class, substance abuse. And then every spring, stats, but then
Okay.
my summers is different.
Did you find out if my class I can use as an elective? No, I'll text you, I'll do that.
Yeah, text me,
Okay,
please. Or email me, that might be better.
yeah, I'll email you.
Okay?
Yes.
Perfect.
Thank you, Professor.
Thank you,
Thank you,
have a good
guys.
holiday.
Thank you
For
so
your
much.
patience, for everything with us.
Thank you guys.